Congratulations, SGPGI team, Dr. Dhiman, and thanks for inviting me. I bring greetings from ILBS with no conflict of interest or disclosures. Just to give an idea of the trends, earlier when we were studying, Hep B was the dominant. Now alcohol is the dominant cause of cirrhosis. This is an algorithm which we proposed. If someone has a DF of more than 32 with alcoholic hepatitis, mortality, can you hear me?
Yeah, we can.
So the mortality is 65% if untreated. And the common pattern would be to give aggressive nutrition, put an NG tube, IV lipids, no sepsis, AKI, DF is less than 90. We give antifungals, antibiotic. This is the initial time. Assess for steroid response. If there is response, continue. If there is no response or is steroid ineligible, which is possible as Dr. Singhal said, then you have alternative options. I will come to it again. I want to start with these concepts. As Dr. Singhal also mentioned, in the 2010 to 17, we had 1,351 patients with a DF above 32. Those who came with jaundice and ascites were 1,135, without ascites 216. 72% were ineligible. 28% were eligible. Of those eligible, non-response was about 27%. So overall, 1 in 5 got benefited, 4 in 5 not. And this benefit was only till day 28. So the questions before us beyond steroids. First, can you predict non-response before starting steroids to prevent avoidable infections and deaths? So these are some of the things which we normally practice. If the person has bilirubin, which is high and it is rising, we almost always do a liver biopsy in our patients. And if Mallory body and ballooning, the index is more than 6, then we feel this patient may not respond. Presence of cholestasis is bad. Urine metabolome is routinely done. Acetyl carnitine of more than 2,500. High TSI. Presence of ASGPR positive microparticles, and if there is a liver transcriptome about which Dr. Singhal said, where the steroid receptors are downregulated, processing of steroids is not there, then we say. So here, presence of ballooning degeneration, presence of Mallory-Denk bodies, this gives us an MB score which we use. Presence of cholestasis or eosinophilic degeneration, such a patient should be rapidly evaluated for transplant. Acetyl carnitine, if the level is above 2,500, survival is poor compared to those. This only shows a shift from a fat metabolism. There is a glycolytic pathway which is responsible. So there is a pump failure, energy failure is the major response to this. The ASGPR, acyl glycoprotein receptor microvesicles. So hepatocytes, once they are dying in alcoholic hepatitis, they will release this. Those who are not responding will have high microparticles. Their size is also large. So even at baseline, before starting steroids, you can differentiate a responder from a non-responder. Here, the cell death is much higher to be handled by steroids. You also can do transferrin saturation index. The TSI, if it is more than 20, you can see that these patients will have poor survival compared to those who have a lower transferrin saturation index. And this shows patients with ACLF have extremely high iron overload. This is called labile iron pool, LIP. So you have a person who has a low hemoglobin, bilirubin is high, mainly indirect bilirubin. Such a patient has low iron available to the cells, but labile iron in circulation is very high. So LIP, which is easily done, is an index by which you can find out steroid response or non-response. Having decided this patient is not good for steroids, what options do we have? Well, this is the rationale for treating SAH. First is to suppress inflammation, steroids, anakinra, FMT, GCSF. Prevent infections, immune modulate, nutrition, remove toxins, or stimulate liver regeneration. This algorithm, I think, is quite interesting in the sense I had presented, but now we have revised it. This is what we follow. DF more than 32, we haven't done with MELD. Nutrition therapy, dietary modulation, omega-3 and branching. First 48 hours, we decide he's eligible or ineligible. If he is eligible, we don't use it, but we can recommend certainly based on the data that 80% plus beneficial response, you can use anakinra. You can also do assess response at day 4 and day 7 if steroid is working. But if it is not working at day 7, you screen for sepsis and then you have a decision curve where you can give GCSF. If he is ineligible for this also or there is no response, LT. If there is steroid ineligible, FMT, plasma exchange, or liver dialysis. These are experimental therapies, so don't believe me till you have tried, but these are acceptable therapies. I want to give 2 minutes for the energy and the nutrition. Now, the prescribed energy is 1800 to 3000 for a patient with severe alcoholic hepatitis. He had been drinking till recently. His energy intake is very low, and therefore, there is very little that you do in the first 9 days, calorie debt. And this is called day 9 syndrome. Patient is admitted with a bilirubin of 5, he becomes 10. Patient thinks this Dr. Sarin doesn't know anything. But the problem is the debt will increase. We have to therefore decide if the patient is to stay longer or on vent or has complications, what nutrition has to be done. This is a separate talk. What we do normally, we put in an NG tube, we will give omega-3. The whole idea is liver regeneration. You have to immune modulate and give also liver regeneration a chance. Positive nitrogen balance, nobody does these studies, but they are vital. Decrease ammonia production, give trace metals, and of course, many other things. This is that famous Mendenhall study. If you give more than 3000 calories, everyone survives. If you give less than 1000 calories, almost everyone dies. This may be simplistic, but it gives you a message that the high calorie people survive. This study, which we had presented in ASLD, by putting simply nasogastric tube and aggressive feeding, it showed that there is an improvement when you do intervene. And if you can give more than 25 kilocalories compared to less than 25, this makes a huge survival benefit. Therefore, attempt to give at least 25 kilocalories and more than 0.8 grams. It is difficult to feed such patients, so put NG tube. Now, saturated fats, the moment the patient has bilirubin high, you can't give fat. This is a common thing, but this is not true. This study by Bernd Schnabel has shown patients with alcoholic hepatitis severe have dysbiosis. In the experimental model, he showed that in these patients, if you give saturated fat, it converts dysbiosis to eubiosis and decreases gut leakiness. This study shows if you are giving saturated fat, the injury is less. With saturated fat, ALT levels lower. You have hepatic triglycerides, which are less compared to unsaturated, and T bars are low. Why not give desi ghee? This study is part of a PhD thesis at our place. And the whole idea behind in this thesis, I'll not take more time, is that saturated fat, they improve adiponectin level, they decrease dysbiosis, permeability is decreased, and there is a possibility that endotoxemia will decrease. We therefore believe strongly that this is a therapy which is worth its try. Now, this is intravenous. All that was oral. This was 2 studies, 2 DM theses. Patients who had high bilirubin and MELD score were given intravenous soybean, 500 calories, 3 days. They were well tolerated. What is interesting to note is that in these patients, this is CLD alcohol, this is severe alcoholic hepatitis. What we were able to do is to have an improvement in the nitrogen balance. The nitrogen balance from -3 became positive by day 3 or day 4, 3 days we gave it. This is a huge advantage that nitrogen turnover is positive. So what is our nutritional prescription to these patients? 35 to 40. Normally you have give 25. 35 to 40 kilocalories, of which 30 to 35% is fat. There is protein, we excess meals and NG tube, and of course multivites and others. Now we come to the second part, which also, like nutrition, may be a little controversial but emerging, FMT. It has several roles. Suppresses inflammation by mate cells. So you have an intestine, mate cells, which are highly active and cause all the inflammation. And we have a plenary in the last ASLD. FMT causes inhibition of mate cell activity. It prevents infections and it also stimulates liver regeneration. So how do you modulate gut bacteria? Diet, I told you, FMT. So fecal microbiota, this slide only shows you people who drink. Some of them never get liver disease because their bacteria are resistant. Some of them are very sensitive to even small amount. Pectin, present in apple and many other things, can convert sensitive to resistant bacteria. That doesn't mean you have an apple and drink. Well, FMT, we had 4 trials. First, steroid ineligible pilot study, FMT versus pentoxifylline. I'll show you data. We didn't publish it as of now. FMT with the steroids, and the 4th one is FMT plus versus SMT, steroid ineligible. The whole hypothesis is modulation of gut microbiota in severe alcoholic hepatitis by healthy donor fecal implantation would improve outcome. This is the FMT lab. The first pilot study, we treated 9, took 18 controls, the first study globally. It showed you that compared to those anecdotal controls, FMT improved survival. It also showed that non-responders at day 0 had more of Klebsiella, E. coli. These are all the bacteria which makes the difference, and Enterococcus. When we gave FMT, and this is a change, that you are having Bifidobacterium, Bacteroidetes, and the other bacteria have decreased, that include Shigella and others. And this I'm not going to detail, but at 12 months also, several of these, especially the branch chain amino acid and isoprenoid biosynthesis, remained good. This is the second trial, which was pentoxifylline versus FMT, and it also showed substantial benefit in survival, ascites, HE, and many other parameters. This shows you FMT mean survival is 81 days, while pentoxy is 54. But since by that time a STOPA trial had come, we didn't pursue this further. This is the study which completed, is an under review. I hope some of our good friends can at least give the benefit. This is a very difficult study, very difficult. 60 odd patients, intention to treat analysis. FMT was as good and gave modest benefit compared to prednisolone. Prednisolone gives benefit till day 28, but this benefit in the FMT persisted till 90 days. This is an important slide. Just to give you an idea, any single change is 0.2 deviation. At day 0 in prednisolone and at day 0 in FMT, the bacterial changes occurred faster. They went into similar line at day 28 and day 90. On the other hand, in the prednisolone, up to day 7, there is a benefit. The moment you stop or otherwise, there will be a regression in the bacterial, good bacteria, I would say, till they reach the end. And it is this period that infections occur. This study of Professor Dhiman in patients with ACLF compared to standard of care FMT had been found to be superior. The study is just coming into Hepatology International. There are several, unresolved issues in FMT. Lille score is good for steroids. There is no score for FMT because FMT starts working after maybe 4 weeks or so. It takes the Shannon index changes after about 28 days or so. Bacteria needs to establish themselves. We don't know the functions of good bacteria. We have identified many which have ammonia reduction or neutralizing functions. Which route is better? Huge debate. Storage of them, liquid, whether related or unrelated, dose, duration, repeating, all these are unresolved. We are in the infancy. I'll now come very briefly to GCSF, which has 3 roles: inflammation suppression. This is mainly by decreasing interferon gamma intrahepatic. Also by inviting the dendritic cells into the liver, immune suppressive disease. And immunomodulation by improving the neutrophil functions, monocyte functions, and regenerative functions. Liver failure, in my opinion, is one word: failure of regeneration. And steroid response failure is failure of regeneration. It is the commitment of hepatocytes to cholangiocytes rather than hepatocytes. That is the major problem. GCSF converts the commitment to cholangiocytes to hepatocytes. It mobilizes CD34 cells. In a patient with compensated liver disease, maybe by alcohol, decompensation, ACLF, neutrophil dysfunction, which leads to sepsis, which leads to liver failure, not liver failure to sepsis, and organ failures. Now, if this patient is given GCSF, improves dendritic cell function, neutrophil function, you prevent sepsis. By preventing sepsis, you prevent organ failures. Also, as shown here, there is an advantage. Liver progenitor cells come out, bone marrow mobilizes cells, and this can lead to liver regeneration. This study showed normal ACLF 30%, you will have CD34 positive cells, but you give GCSF, this number becomes 70%, leading to a survival benefit. The study by Professor Virender Singh in alcoholic hepatitis, where he compared pentoxy from GCSF, here it shows you there is a distinct advantage of using GCSF with improved survival. In this study, which was very difficult, this was Shastri's thesis, we gave steroids, those who failed. Of them, 33 patients, non-responder, were taken in. Of them, 28 actually GCSF versus placebo. GCSF gave an advantage to placebo. All patients are not good for GCSF. So please do not use patients of GCSF if there is sepsis, if there is HLH, if there is a renal dysfunction, or patient has marked sarcopenia. In them, wait and then only start. Or even if you start, now the study which we just completed, where we have compared steroid plus GCSF versus pure GCSF, a lower dose has been used for the benefit. The last 2 slides will show you that patients who have got ACLF or have severe alcoholic hepatitis, plasma exchange is superior to Prometheus or liver dialysis. So you do plasma exchange in them, there is a better cumulative survival at day 28. So in my last slide, one more time, we have a problem. 4 out of 5 patients are either steroid ineligible or have no response. Only 1 out of 5 will actually come into where you can continue steroids. Even in them, as Dr. Singhal showed in his gastro paper, that there is a high chance of infections which occur between day 28 to 90 or third week onwards. Therefore, mortality is still high. But those who do not respond or ineligible, we have very few options. One is the SHIT therapy. I think it will become palatable in times to come. But yes, plasma or anakinra or maybe GCSF, much more data is required before we say. Thank you for your kind attention.